Hello, everybody. My name is Bradley Smedley, and I'm a third-year community college student at Cabrillo College in Santa Cruz, California. I'm working towards my associate degree in biology before I transfer. And today I'm going to be sharing what I've learned about hepatitis C, a care among incarcerated populations. So this summer I've had the privilege of interning here at the Sage Center of Health and Justice, and my PI was Emily, who is the founding director of the Sage Center, and Janarius was my mentor. Yeah. So I just wanted to start by touching on some background information I think is important. My father was incarcerated when I was 6, and he remained in prison for 18 years. He was released 2 years ago, but during his incarceration, he contracted hepatitis C while he was in prison. And he wasn't able to access testing or treatment while he was incarcerated. And when he was finally released, he was able to get tested and treated, but because he had hepatitis C for so long in prison, his liver got diseased and progressed to stage 3 liver failure. And they told me I had a maximum of 5 years to live without getting a liver transplant. And when I arrived here at Yale, Emily Engineers gave me the opportunity to work on whichever project I found most interesting. And at that point, the hepatitis C project wasn't in the cards because it was like in its infancy. But after I shared my father's story with Alana, she mentioned that there was a hepatitis C project that was starting and that she advised I look into it. And after thinking about it, I came to the conclusion that if I could leave this summer with a better understanding of how the correctional system failed my father, I'd be extremely grateful. And that's what I got from this experience. I have a better understanding of how hepatitis C works in the correctional systems across the United States. And that's exactly what I'm going to walk you guys through today. So before I get into the nitty-gritty, I first want to cover what is hepatitis C. Hepa means refers to the liver and itis refers to inflammation. So hepatitis quite literally means inflammation of the liver. And throughout this presentation, you might hear me refer to hepatitis C as HCV, which just stands for hepatitis C virus. And the HCV is a virus that lives in the liver and uses our own liver's enzymes and proteins to replicate itself. And once it's in our bodies try and fight it off by attacking our own liver cells. And over time, that repeat and attack process. So I'm getting my laser pointer. Creates scarring over the liver, and that's a condition we know as cirrhosis. And it happens to the point where our liver can no longer function. So I created this concept map to show you a little bit more of what hepatitis C was in depth. So we start with hepatitis C in the United States, simply defined as a liver virus. Good news, there's a cure, direct-acting antivirals. These cost about $20,000 per treatment per person, and it takes roughly 8 to 12 weeks to complete treatment. On the general population side, we have about 2.4 million Americans, or roughly 1%, that are currently living with hepatitis C. How is this contracted? It's contracted blood-to-blood transmission through sexual intercourse, through shared nail clippers, razors, needles, mother-to-child transmission. And before 1992, we didn't screen blood supplies, which consequently allowed HCV to spread during transfusions and organ transplants. Who's most at risk? Opioid use disorder, substance use disorder, and injection use disorder, or anyone just sharing drugs and needles are most at risk. In terms of symptoms, people would experience acute symptoms between 2 and 12 weeks, like muscle pain, joint pain, dark urine. But a lot of people would skip straight to chronic symptoms like easily bruising, weight loss, confusion, drowsiness. And this can all go on for 10 to 40 years in your liver as a silent battle before anyone realizes anything is wrong. And if this is left untreated, this can lead to death. In the general population, we see about 4.3 deaths per 100,000 people. And in the state prison population, that number more than doubles with 10 deaths per 100,000 people. So that's why this population deserves a closer look. So again, why specifically focus on incarcerated populations? The numbers make their own case. For example, HCV seroprevalence, meaning the detectable levels of HCV in your blood, is 13 times higher in the correctional system setting than in the general population. And incarcerated people account for roughly 30% of the entire US hepatitis C burden, despite being a small fraction of the overall population. And yet, only 33 states are currently offering routine opt-out screening in their prison systems. So we have a population that's disproportionately affected, moving through a system that in 17 states isn't even set up to catch it. So I made one last concept map to show you what exactly happens or doesn't happen when someone enters the correctional system. I want to say up front that this is heavily simplified just to give you guys a general shape of the problem the time we have today. So we're going to start with hepatitis C flowing into the correctional systems. And from there, everyone ideally loops into the opt-out testing, meaning everyone is routinely informed that they'll be tested unless they actively choose to decline. Right now, only 66% of states offer routine opt-out testing, and for that 66%, the pathway is testing leads to diagnosis, positive diagnosis leads to treatment, which takes 8 to 12 weeks, and full treatment leads to being cured, which means having a sustained viral response, which means the hepatitis C remains undetectable in a person's blood after treatment has ended. And I want to just specify that because the virus may be undetectable after the medication ends, that doesn't mean they're cured. Cured is when you do an HCV RNA blood test that remains undetectable 12 weeks after the final dose of medication. After this, you're ideally released back into the general population and then ideally transitioned to the transition clinic network. And I've highlighted this pathway in gold because I think it's the ideal pathway we want everyone to follow. But it is possible that on this road, you can get diagnosed with HCV and then not meet all the stipulations to receive treatment. For example, your jail sentence isn't longer than the length of needed to complete the treatment, which is this roadway right here. And there's another roadway where you can start treatment but not receive the full treatment due to several factors, like, for example, early release, and that is this pathway right here. Now I want to talk about the other pathway where there's 34% of states don't offer routine opt-out testing. And without testing, there is no diagnosis, and which means no treatment, and people are released back into the general population without ever being cured, and often without ever even knowing their status. And it's really likely they won't be referred to a TCN clinic. And this matters beyond the individual too, because roughly 2/3 of people who are released from prison are reincarcerated. And this gap in testing follows them right back into the system and back on through the cycle all over again. So I know that was a lot, so I simplified it a little further and it's down to 3 major steps. So step 1 is screening and diagnosis. Step 2 is treatment and confirmed cure. And step 3 is continuity of care after release. I could have picked any one of these to dive deeper into today, but I think each one has its own research problem. And for the sake of time, I just chose the one that interested me the most, and that was step 3, continuity of care and transition back into society. And also at step 3, I think this is where the whole cascade collapsed the hardest because someone, for example, can be tested, diagnosed, and even receive a full cure while in custody, but I'll lose all of that the moment they walk out the door. So let's talk about what's actually happening at release. Even the best documented programs in the country still see this drop off. So, for example, in Connecticut, which has one of the most complete HCV care cascades of any correctional system in the country, only 63% of people with chronic hepatitis C started treatment, and only about half of those had a confirmed cured data afterwards. So even in a strong system, release is where I believe things start to fall apart. And here's what's actually already being done: discharge referrals, appointment scheduling, Medicaid reactivation, and transitional care and patient navigation. And here's what's still missing: a reliable, warm handoff between jail staff and community providers, integration with substance use and mental health care, basic logistical support like transportation, phone access, housing, social support, and follow-up care all the way through HCV or SRV12 cure test to actually confirm whether someone stayed cured after release. And this last step, this last point is where I saw a gap across almost every paper I read, that no one is consistently tracking whether people actually get confirmed cured after they leave custody. So given that gap, this is what I'm going to recommend as the next step: a study that directly compares outcome for people released through a structured transition of care model versus those who receive a standard discharge referral. Specifically, I would compare linkage to care rates to confirmed HCV cure rates. And in simpler terms, we're asking, is actively helping someone transition into community healthcare actually make them more likely to see a provider, complete treatment, and be cured of hepatitis C? And a structured model could include scheduling appointments before release, transferring medical records, helping with insurance and medications, and having someone follow up afterwards. And that would just be compared with the standard approach where someone may simply just be given a referral or a phone number or just their discharge paperwork and be expected to navigate the healthcare system all on their own. And this is where the TCN network comes in. TCN was created to address this exact problem. It builds community-based and patient-centered healthcare for people returning from incarceration by connecting them with primary healthcare, behavioral healthcare, and social services with a particular focus on managing chronic health conditions. And a major part of this model is hiring community health workers, often people with experienced incarceration themselves, and integrating them into the medical team. These workers help patients navigate medical care, insurance, medications, transportation, and other social services. TCN also partners with community organizations, the correctional systems, and government agencies to create a more coordinated transition from incarceration back into the community. And this summer, I've had the chance to shadow a TCN clinic here in New Haven firsthand to see the direct impact it's had on people's lives. And it really inspired me. For example, watching the way individuals' faces would light up when Manya, the community health worker I shadowed, would enter the room was incredible. She has an infectious personality and a super positive outlook on life, and it's very inspirational and undeniable. And that's exactly why the community health worker aspect of the TCN is the entire key to making this approach as successful as it is. And I just want to close by talking about how I'm planning to get involved with the TCN in my own community once I get back. Janaris and Emily are linking me with one of the closest locations to me, which is in San Francisco, which is ironically the first ever TCN location opened up by Emily. And my plan is to transfer to UC Berkeley, and if I don't get in there, then go to Davis. And regardless, wherever I end up going, I want to volunteer at a TCN location closest to me and get back in whatever way I can, whether that's just helping out with like paperwork or maybe becoming like a community health worker myself. I'm excited to give back and get involved. And I want to give a huge thank you to the SAGE department for this opportunity I've had this summer, and a special shout out to Janarius for being such an amazing mentor and never making any question I ask feel too uneducated to ask or like not worthy of asking. And also for making me feel worthy of being there at Yale. And my biggest takeaway is the foundation of research skills and my experience I'm walking away with, skills that I plan on taking into my next research opportunity. So thank you guys so much for making my summer amazing, and I'd love to take any questions.
Thank you, Bradley. And any questions? Actually, Bradley, so number one, this is a great sort of synopsis. A good review even for me who knows a lot about this, or sort of all the things to know about hepatitis C care and sort of how it can interact with the criminal justice system. So I really appreciate it. So clearly you learned a lot about both hepatitis C and the correctional healthcare system in your summer here. You mentioned sort of kind of what you practically are going to do, sort of getting to go to Southeast Medical Center, et cetera. But so what are you going to do? What do you think you're going to do with this sort of knowledge you've gotten? Like, are you going to do, imagine, sort of for the research project, focus on hepatitis C or something like that as next steps?
That's a great question. So I do want to continue following the hepatitis C project that's starting right now at SAGE. It's still like very much in its infancy, but it's something I look forward to following and seeing how the project's going to take off and how they're going to be able to help in whichever way they plan on helping. And I think just getting this knowledge this summer like helped me with my direction in life on how I didn't realize how bad the transitioning from incarceration back into society was. I only had the example of watching my dad, like extremely privileged way of coming back into society, but watching like going to the TCN clinic and watching people transition back into society and how hard it was, like humbled me and realized that I could potentially like make a difference in people's lives by volunteering some of my time at a TCN location, like regardless of that's like helping people like get connected to resources in my community or just being a person in their life to help them. That's kind of what I'm taking away with this summer.
Thank you.
Yeah.
Bradley, this is Rachel. This is so beautiful. And I think I'm like moved in general by your presentation, but just struck by the amount of insight you have into a process that I've like observed in clinic and then spent time in like a jail system looking at like your insight into a process that you have like not had a wealth of experience being such close proximity to just speaks to the maturity with which you've approached this. So I just thought that was amazing. And then one thing that's sort of independently on my mind is about folks who are re-institutionalized. Like I'm currently working on a project about how people bounce in and out of like jails, prisons, psychiatric settings. And one thing that's striking to me, both like on the inpatient side, is like a lot of times the meds don't transfer with them. These are like expensive meds that are not generic. And so it's not always something a given hospital will dispense. Like you come in with your medication list and it says, oh, this person's on treatment for Hep C. Sometimes you actually have to bring it in yourself, depending where you are. So just another thing in the reentry space of folks who are bouncing back into the jail system or otherwise. I think it's really hard to stay on the medication. And even in like it's various states I've heard conversations about just like not wanting to make that upfront payment of $20,000 if someone's like not going to be able to continue it or going to have a disruption in their care, which I think is kind of a self-defeating argument, personally. But yeah, thank you so much for this. This was amazing.
Of course. Thank you guys.
Riley, I just wanted to say, in addition to being so impressed by your personal investment and all you've learned, you're a very talented visual map maker. It's just beautiful how you sort of demonstrated. And then just a question for you or others in the room that know about Hep C treatment. Could you talk about the rapid treatment process? Because I know it's just, if anyone knows about that, I'm curious.
Biologically, I did not learn about how the direct acting antivirals work in our bodies, but I would be interested to hear if anyone had that figured out.
I mean, I'm sure you looked up some of the work by the folks in Rhode Island, Justin Burke, who's been doing a lot of work in the Rhode Island Department of Corrections, but they've started looking at partial, so people who get sustained viral sort of remission with partial treatments or potentially don't need to complete the whole treatment. I don't know if that's what you're implying, but definitely sort of partial treatment has some benefits, and also just physically handing people the rest of their meds when they leave the corrections. They're kind of working on that to be instead of expecting someone to go to a pharmacy to pick up a med. But I feel like they're seeing some results on partial treatment actually is effective. Not as effective, but it can be effective for some people. And actually sort of system-based processes of just actually physically handing people the rest of their meds as they go. One challenge that I don't think the one thing you might add in your map is that I will say what they see is a lot of people get SVR12, and then because some of their underlying sort of risk factors aren't addressed, they then sort of get reinfected. So they see pretty high reinfection rates with hepatitis C, with a new genotype or something. Yeah. But it's just something to add in there that if you're not treating sort of the risk factors, you're just going to set people up. Of course, because the prevalence is so high in sort of injection drug using communities, the likelihood of getting infected is very, very high.
Yeah. So you have one other path, Bradley. Yeah. That's right. And they are. This is to Alana's question. So there's two new things that are coming down the pike as a rapid test for HCV. So point of care, test positive, start treatment, which would help settings like jails, especially in Connecticut, that is doing a kick-ass job except for jails. And then two, it's 6 weeks. So they're testing it in a clinical trial now through the Connect network. 3 sites, 3 jails. Matt Akiyama is leading it. Yeah. Amazing. You're literally at the cusp of science, Bradley. You know exactly what they should be doing. That's right.
Can I ask, does the pill have to be directly observed or
no?
And so in jails and prisons, do people get a week's worth of pill? Or how does it work? Every single day?
Or I think it probably depends on the facility, but I've seen a lot of issues with dispensing not the correct amount, underdosing people, but every day there's a person that's maybe not familiar with the medication dispensing it. And then to your point too, and I think there's data that's now a little older, but just that we don't need to be doing such rigorous lab monitoring on these folks too. I think that was a barrier where they were oh, well, so-and-so's not going to be able to come in and get their blood drawn or monitor how they're doing on this treatment. And there's little evidence to support that they really need such frequent monitoring to preclude people.
It was weekly to start.
It was insane, yeah. Very burden on it. And if you think about the population, it's that's impossible.
It's impossible for me.
I would like to thank all our 4 students.
Yeah.
Yeah, it was always so loved.
Yeah.
Lit up when you entered the room.
And then
Thank
you.
you. Thank you.
Yeah. I'm like,
Okay, I'm gonna stop recording because so we wanted to get this